So now we can turn our attention to the big kahuna when it comes to dementia, Alzheimer's disease. Like 2 out of 3 people who are demented ultimately are diagnosed as having Alzheimer's disease. So it is the 900-pound gorilla in the room, so to speak. So let's look at some important facts concerning Alzheimer's disease. We already know it's a chronic, incurable, and deadly brain wasting disease. We also already know it's the most common variety of dementia. Interestingly, the disease was first chronicled by a physician named Alzheimer in Europe in 1906. And I say interestingly because his patients he looked at and diagnosed were actually not old people, they were middle-aged people. And until quite recently, Alzheimer's disease was classified as a form of what we call pre-senile dementia. That is, it was a form of dementia that struck middle-aged people rather than old people. We now know that that's not the case at all. But what Alzheimer's studied this group of patients who were middle-aged, and what he found when he examined their brains was the classic, if you will, diagnostic criterion that still exists today for Alzheimer's disease. Namely, you see this accumulation of amyloid plaque in the interstices between adjacent neurons in the brain. It's a buildup of kind of gunk that we'll look at more closely in the next lecture when we look at mechanisms of Alzheimer's disease. And inside the neurons themselves, there were these neurofibrillary tangles, these little structures that looked like tumbleweeds that were really destroyed structures inside the cytoplasm of the cell that's associated with an aberrant tau protein, as we'll look at again when we explore some of the mechanisms of Alzheimer's disease. So to this day, since Alzheimer described the presence of this plaque and these tangles in the brain as the definitive diagnostic criteria for the disease, that's still the definitive diagnostic criterion. We cannot be sure that a person has Alzheimer's disease until we perform an autopsy and see these 2 signatures. Nonetheless, given its high prevalence, it's usually the default diagnosis when people present with dementia. And we'll go through that diagnostic process a bit. And essentially, what we try to do first is establish the person does have dementia, and then try to rule out all the other causes of dementia. And we can't find any other cause, guess what? We call it Alzheimer's disease, so to speak. That might be one of the reasons why the number is so high, that 70% of people with dementia are classified as Alzheimer's. It could be that there's many different dementias that we call Alzheimer's disease, just like there are many, many different types of cancer, so to speak, that fall under the same rubric of cancer, but they all have to be treated in very different fashions. So here's a checklist for Alzheimer's dementia, and if you go through the checklist, so to speak, I'm not going to spend much time on this here. I'm presenting to you as a tool. What you'll see is you show there's a memory loss. You see one or more of these cognitive functions. You say, oh yes, it is essentially interfering with social and occupational activity. It's characterized by a gradual onset and continuing decline. Okay, it meets that signature. And then we go on to see, oh yes, we can rule out certain other explanations. And when we rule out those other explanations and say that it doesn't occur just in the absence, just in the delirium state, we check all the appropriate boxes, and then we can essentially make the decision that we're looking at somebody with Alzheimer's disease. So in fact, let's follow this little flow chart of how a typical diagnosis of Alzheimer's disease might occur. So now we have someone starting up here in the flow chart with a memory complaint and some complaints about cognitive function decline. So now they present themselves to the clinic, and a medical history is done, some functional and psychiatric evaluation, maybe a mini mental state exam is given to them. There's a neurological makeup, interview with the caregivers to try to get additional information from the situation. And the first decision has to be made here is, does it meet the criteria for dementia? That is there memory impairment? Is there one or more cognitive problems? And does it interfere with their task of daily living? If they don't meet the dementia criteria, they come over here, and some essentially people look for depression or some other disturbances. But if they do meet the criteria, we continue down the flow chart. Okay, so is the cause of dementia as a parent? Is there history of Parkinson's disease, for example? Or has there been some sort of head trauma, or maybe exposure to carbon monoxide, an anoxic event, so to speak? If yes, okay, then we found the cause of the problem. But if not, then additional laboratory tests have to be done to see if there's hypothyroidism or B12 deficiency or syphilis or encephalopathy, that is inflammation of the brain due to HIV, so to speak. And if we can rule all those disorders out, remember we talked about those acute conditions that can mimic dementia, we can rule those out, we continue to go down the list. Now maybe some neuroimaging studies are ordered. Is there any abnormal neuroimaging that might be indicative of vascular dementia or of some other problem like multiple sclerosis or a tumor in the brain? If that is negative, we continue down. We do a motor system assessment, right? In the motor system assessment, that would be indicative of some other types of dementia, for example, vascular dementia, or some of the, if you will, some dementias related again to Parkinsonism or Lewy body, or very, very rare Jacob-Jacob disease, that is mad cow disease. We rule those out. We're finally down to this box. Is there evidence of depression? Normally that's based on the history of workup done with the individual and looking at their medical files. Okay, you can rule out depression. Now that ultimately takes us to the final box. At this point, we're essentially confronted with someone that probably either has Alzheimer's disease, frontotemporal dementia, or Lewy body dementia, so to speak. One looks for some essentially in Lewy body dementia. Imaging studies can help us diagnose that. In terms of frontotemporal dementia, the signs of that typically have to do with really, really dramatic personality changes that are rarely seen in Alzheimer's disease. That could help bias the diagnosis towards frontotemporal dementia. And if it doesn't end up with a frontotemporal or Lewy body dementia, by default, what do we have? Alzheimer's disease. So that's typically the process that one goes through, and that's why I refer to it as a default diagnosis for dementia. And what I'm showing you here in the slide is what a end-stage Alzheimer brain looks like compared to a normal healthy brain. And look at the amount of loss of cellular mass in the brain. It's just a shell of what it used to be. No wonder our function declines so dramatically and we ultimately die from this disease. It is a terrible brain wasting disease that has dramatic effects on our central nervous system. So let's look at some other characteristics of Alzheimer's in terms of how many people it kills. It's the fourth leading cause of death in the United States. It's only behind heart disease, cancer, and stroke. It affects currently 1 in 10 persons over the age of 65 in the United States. 1 in 10 persons over the age of 65 is affected with a diagnosis of Alzheimer's disease. That's right now today represents 5.5 million Americans. The age of onset of Alzheimer's disease, different than what we see in cardiovascular disease. The vast majority of the victims are over 65, and the probability of diagnosis increases exponentially beyond age 65. Very different than the mean age of onset of what? In our 60s. in a case of cerebrovascular or vascular dementia. And if we look at this plot here, it shows you this exponential rise in the, if you will, prevalence of Alzheimer's disease as we go from age 65, where we see only 2% of the 65-year-olds have Alzheimer's disease. By the time we get to 85, 20% of those 85 have Alzheimer's disease, and the curve just keeps going up from there. So as I said earlier, about 5.5 million Americans currently have this diagnosis, and that is projected to double by the year 2040. It's doubling by the year 2040, not because Alzheimer's, we're becoming more susceptible to it. It's just a matter of demographics. It's as those baby boomer generation people like myself who've moved into the post-retirement years, as they get older and older and older, more and more and more of them are going to come down with Alzheimer's diagnosis. And that's where we're seeing this explosion of Alzheimer's cases in the country. Right now in South Dakota, we're not a very populous state, but even we have 17,000 people have been diagnosed with Alzheimer's disease in our state. And again, to give you an idea of how strongly associated to advanced old age Alzheimer's is, 82% of the people who are diagnosed with Alzheimer's disease are over the age of 75. So essentially, think about that. That means 18% diagnosed are below 75, 82% are above 75. It definitely is advances for every year that our age increases beyond, let's say, age 70. And the majority of all nursing home residents are there for what reason? Because they've been diagnosed with Alzheimer's disease. It really is a bleak and devastating condition. If we look at the gender distribution of the disorder, we see just the opposite of what we saw in, if you will, vascular dementia. The lifetime risk of coming down with Alzheimer's disease, that is, what is the risk that you will ultimately get Alzheimer's disease? If you're a man, that risk is 10%. If you're a woman, that risk is 20%. You're 2 times likely to ultimately someday get Alzheimer's disease if you're a woman than if you're a man. And we can ask ourselves, why is that the case? And the best explanation that we have for that now, and the data kind of supports this explanation, is that the reason we see this twofold lifetime increase in risk in women is because women simply live much longer than men. And remember, we saw that very, very strong association between advanced age and coming down with Alzheimer's disease. Well, we have many, many, many more women in that 80 and older group than we have men, because the men are dying from other reasons. And therefore, the women are more likely to have the opportunity to develop Alzheimer's disease, and indeed they do. And that's our best explanation for why we see this strong bias, if you will, in prevalence towards women for this disorder. Again, one of the characteristics of Alzheimer's disease is gradual onset of symptoms instead of sort of a sudden presentation type of event that's more common in vascular dementia. The brain damage is pervasive in Alzheimer's as opposed to localized, as we see in the cardiovascular form of dementia, and therefore all the cognitive functions decline together. We don't see little islands of cognitive function being spared in Alzheimer's disease. Everything is trashed. We don't see the maintenance of good judgment capabilities that we might see in some vascular dementia patients. Its ability of good judgment goes down universally across the board. And again, the decline is a steady, continuous decline rather than that sort of stepwise type of function we saw in the case of vascular dementia. What kind of survival time do we typically see following an Alzheimer's disease diagnosis? Well, the typical value is somewhere from 4 to 8 years. It's really kind of highly variable, but 4 to 8 is pretty much what you can expect in the typical case. Although there are many cases that have been documented of people that have lived 20 years after a diagnosis. And so this 4 to 8 year window is longer survival, if you will, time than we saw in the case of the, if you will, vascular dementia. And this reflects that slow, insidious deterioration of the brain. And in fact, we believe that Alzheimer's disease, its impact on your brain, usually starts as many as 20 years before the first symptoms present themselves. So let's suppose you might actually, if you had a crystal ball or you had a time machine, once someone's diagnosed, if you could go back 20 years, you could probably begin to see signs of changes in their brains that far back. But it's so slow and so insidious that a lot of the brain has to be destroyed before we begin to see functional declines. And that is actually something that's of great interest to researchers. Because the destruction is so slow and starts so long before the symptoms are presented, one of the strategies people are thinking about in terms of handling Alzheimer's disease, and I'll come back to this again later, is that if we can diagnose it early enough, even if we can't cure it, we can begin to really slow it down, perhaps with custom designed drugs that will intervene. If you will, you start taking the drug 20 years before you show the symptoms. And if we can slow the progress down by, let's say, 10 or 20 years, you know what? Chances are pretty good you'll die from something else before you ever begin to suffer the cognitive declines that are associated with Alzheimer's disease. So being able to diagnose it early is part of the strategy that sort of the Alzheimer's community is beginning to concentrate on as they search for some pharmacologic agents that will not cure the disease, but at least perhaps slow it down. So, okay, so we said that we could expect a 4 to 8 year window of survival following a diagnosis, but the sad part of that is that almost half of that time will be spent in the terminal phase of the disease. That is where the person's functions are so diminished that they're going to require 24/7 continuous nursing home care. And at age 80, 75% of Alzheimer's patients are institutionalized, and 2/3 of them die in the nursing home. Those are the numbers. That's what happens. So what I'd like to do at this point is try to talk about the progression of the symptoms of Alzheimer's disease from the beginning to the end, using a sort of a stage, if you will, framework that's been made available from the ADRDA, which is the Alzheimer's Disease and Related Disorders Association. And we're going to see 3 stages. We're going to see the first stage, then a second or middle stage, and then the final terminal stage, stage 3. And let's look at their rubric, their framework. They're trying to just give us an idea of what to expect in terms of development of disorder as we go from the beginning, the first detection of the disease, to the final death of the patient at the end. So we see in the first stage, we see it begins with forgetfulness and impairments in judgment, and an increasing inability to handle routine tasks of daily living. This loss of spontaneity, this loss of desire to want to go out there and do things, a loss of initiative. We begin to see disorientation for time and place developing. Gee, you don't know if it's you're going to your morning meal or your evening meal, so to speak. Problems with like, where am I? Type problems or disorientation for place. And at the end of the stage, the ADRDA point out, we typically see lots of depression and even a sense of terror. And this is, at this endpoint where the disorder has progressed enough, where the patient really knows that their life is about to change dramatically, yet they still have enough cognitive wherewithal to be able to realize the dire situation that they're in, and the unbearable load they're about to place on their family and loved ones. This is a point of where people really get depressed, and particularly men, we see a lot of suicide during this particular, if you will, point of disease. So the condition has progressed to the point where it's seen that it's quite horrible. The diagnosis has been made. People have enough wherewithal to know what is about to happen to them. And it's not surprising that a large number of people may take their own lives at this stage. Interestingly, this is primarily a phenomenon in men. It's very rare to come across women who take their own lives in this situation. It's primarily a phenomenon of older men who've been diagnosed with this condition. And so at this point, the symptoms get worse and give way to the second stage within terms of this framework. This we begin to see wandering, maybe at night, and wandering around the house, maybe wandering around the neighborhood. The perseveration of behavior, so to speak, that's a common type of problem you see here. You can imagine seeing someone who went to the kitchen to get something, let's say out of one of the drawers in the kitchen, and they just kind of, they doing that behavior, but they kind of lost track of what it was they were trying to do. You might see them opening and closing, opening and closing, opening and closing the drawer, and that maybe is where the utensils are kept in the kitchen. And they just get caught in this kind of perseverative loop of motor behavior. That's a sort of a common type of symptom of the disease you would see. You see increasing problems with disorientation for time and place. Forgetfulness becomes increasingly problematic. You might begin to see some behavioral problems like agitation and restlessness present itself. And as we progress towards the end of the second stage, people begin to lose the ability to attach meaning to their sensory input and perception. They completely lose any ability to think abstractly. You might even be able to see motor cortex begin to get involved with the disease. So you could see some motor symptoms like maybe twitching and seizures developing. So the brain is really beginning to get destroyed by this point in the disorder. And then we entered a third or terminal stage of the disease. And this is where essentially everyone in this stage is going to need 24/7 care. They're typically going to be in a nursing home. So you're going to see complete dependence for all activities of daily life here, whether it's dressing or eating. People, you have to feed people, they can't feed themselves. You see disorientation for not only time and place now, but for people. People don't even recognize their own children anymore. And it gets so bad, they don't even recognize themselves in the mirror, so to speak. Talk about the loss of your mind. You essentially can't even recognize who you are anymore. We see severe speech impairment developed at this point, perhaps to the complete loss of the ability to speak. That is complete muteness. And according to the ADRDA, we see lots of people in this stage develop what they refer to as a morbid need to sort of put everything in their mouths. And actually some famous authors have written about this in terms of Freudian psychoanalytic, if you will, rubric. And they see this, as the mind is destroyed, that we regress back to the earliest stage of Freudian psychosexual development. That is, we revert to the oral stage of development. It's kind of an interesting theoretical way to look at the situation, but not being quite a strong advocate of the psychoanalytic approach, that doesn't really kind of blow up my dress, so to speak. But nonetheless, it is a point of view that's shared by many psychiatric, if you will, practitioners. There's also this development of the necessity to touch and grope everything. And this is consistent with this regression idea as well. And probably as you lose your abstract thinking capability and the loss of access with the lexicon of your words that you previously could associate with different types of, if you will, conditions and situations and objects, it's probably not surprising that one falls back on touch and groping to try to get some understanding or contact with the world around us. Finally, your physical body becomes so emaciated and wasted away that you can't even get up and move on your own. Maybe you'll see full-grown, robust men reduced to, let's say, 70-pound, sort of Auschwitz-looking skeletons. There's a complete loss of all bodily functions. That includes any kind of toileting function. So you're in a diaper 24/7. And then a bullet I don't have on the slide is ultimately death is the final symptom of the disorder. A very sad state of affairs. So now we have to take kind of a deep breath that we've gone through those stages, the depressing 3 slides of the first, second, and terminal stages of the disorder. And let's kind of get back to a little bit more straightforward consideration of Alzheimer's disease, and that's the risk factors. And by far the most powerful risk factor for Alzheimer's disease is your age. And it's extremely powerful, as we saw that prevalence curve. Every year you live past age 70 or so, your risk goes up, 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 up. And you know, it's almost as if you could live, if you were to live to, let's say, 140, you would, if you follow that curve, you would surely, like 100% of the people would get Alzheimer's disease. So it is really, really very, very tightly linked to age. But we also saw perhaps the next strongest predictor is sex. Women are twice as likely to get it. But again, the intermediary of that seems to be the mechanism causing that sex difference seems to be longevity, age, if you will. There's a relatively weak but statistically significant relationship in terms of familial inheritance. That is, if you had a parent or a brother or a sister that was diagnosed with Alzheimer's disease, you have a slightly elevated risk of being diagnosed yourself. Recently, we found that sleep disorders seem to place you at a risk of Alzheimer's disease, and the potential mechanism there is during sleep, many of the byproducts of metabolic activity in our brain cleared out during deep sleep. And in sleep disorders, perhaps we don't get those clearance mechanisms working very well, and we could get a buildup of, if you will, biological detritus in our brain that ultimately could lead to this disorder we call Alzheimer's disease. That's an interesting idea that people are exploring now. We know that statistically, people with sleep disorders are more likely to get Alzheimer's disease, but we're trying to get the definitive evidence for why that relationship exists. Excess alcohol consumption across your lifespan seems to be place you at a slightly increased probability of getting the disorder. And then finally, there's a genetic link there. Biologists have discovered a gene called the APOE gene, and there's several different varieties of the gene. One of the varieties of the gene actually seems to protect us against Alzheimer's disease. We're less likely to get it than the general population. But the strongest relationship exists in people who inherit a particular variant of the APOE gene called the E4 variant. And if you happen to get a copy of the E4 variant of the APO gene from both your mother and your father, so both copies that you have in your DNA of the APO gene, both are of the E4 variety, then you have an increased risk of developing Alzheimer's disease. And I have parenthetically a description of what that increased risk might be from a quantitative point of view. So first of all, we look in the general population, what percentage of people have the E4 variant copies from both of their parents? That's only 2% of the population. So that's 1 in 50 people in the population have this particular genetic disposition. That is, they have the E4 gene from both of their parents. But yet, if you look at the people who have Alzheimer's disease, 11% of them have Alzheimer's disease, have the double E4 variant from both of their parents. So even though they make up only 2% of the general population, they make up 10% of the Alzheimer's population. So they're really overrepresented in the Alzheimer's population. So clearly there's something about that gene that is related to Alzheimer's disease. And when we talk about the mechanisms, the research that's been done into the causes for Alzheimer's disease, we'll see this genetic mechanism at play again, and perhaps try to get a little deeper understanding for why it would be having a certain gene could lead to specific changes in our brain that in turn seem to be related to this syndrome we call Alzheimer's disease. So what's the treatment for Alzheimer's disease? Well, I would essentially tell you there's no treatment for Alzheimer's disease. Some people would argue with me with respect to that, but there's certainly no cure for Alzheimer's disease. And that many of the recent tests of promising drugs have been very, very disappointing. I'll talk a little bit more about drugs for Alzheimer's in just a moment, but before I do that, I want to mention that perhaps one of the interventions that might help a little bit to slow down the progress of the disorder, but just slow it down a little bit, are aerobic exercise programs that have been carried out in institutionalized settings, so to speak. And that is people that have regular aerobic exercise and have a higher level of aerobic fitness. That seems to help a bit with respect to the brain deterioration associated with Alzheimer's disease. And you may recall earlier in this course, in the first unit of the course, when we looked at sort of the biological changes that occur with aging, in particular, changes in the aging brain, we saw that one of the things aerobic fitness can do, along with caloric restriction, is it can change the expression of different types of, if you will, potentials in our genome. And that's what I guess is happening in this aerobic fitness intervention, that when we become more aerobically fit, some genes get downregulated, other aspects of genes get upregulated, and that may help benefit Alzheimer's victims in one way or another. So with that being said, let's look at the drugs that have been approved for treating Alzheimer's disease. There's 5 drugs, at least 5 that I know about, that have been approved by the Federal Drug Administration for treatment of Alzheimer's disease. And all 5 of them really have very, very small effects. They have just measurable effects in cognition. And because of the progressive decline in Alzheimer's disease, the little bit of benefit you get from taking the drug is quickly going to get canceled out in 6 months of progression of the disease. So think of what it does is it might take that continuous curve that we saw, the loss of function over time, and maybe shift the whole curve maybe by 6 months, so to speak, in terms of where you might be at in terms of your functionality at any given time. So they're statistically significant effects, but they're very, very small effects. It's really quite disappointing. And there's two classes of drugs that have been developed. And we'll understand how both of these drugs work in more detail when we consider, again, the next lecture, where we look at mechanisms, or at least theoretical ideas about what might be causing Alzheimer's disease. And the first class of drugs include the brand name drugs Aricept, Exelon, and Residine. And those are both drugs that essentially inhibit a brain, if you will, molecule called acetylcholinesterase. And what acetylcholinesterase does is it gobbles up and destroys acetylcholine, a neurotransmitter related to memory that's secreted by neurons in the brain. And the reason those drugs were essentially developed in the first place was because of what we call the acetylcholine theory or the cholinergic theory of Alzheimer's disease. So we'll see what that theory is and why it would predict that these drugs that inhibit acetylcholinesterase should help victims of Alzheimer's disease. And indeed they do, but remember, it's a very small effect. And there's another theory of Alzheimer's disease that says that one of the mechanisms might be that there's a glutamate toxicity mechanism. That is, that neurons that essentially, if you will, secrete the neurotransmitter glutamate tend to be poorly regulated, and they overstimulate their essentially NMDA receptor targets. That in turn causes too much calcium ions to flow into the neurons in the brain, essentially poisoning them, leading to sort of, it's a neurotoxicity type effect. And so what this other class of drugs called Namenda and one called Nemzaric, which is both Namenda plus Aricept up here combined together, those are the other two drugs. What they do is they bind to these NMDA receptor sites. And once they're bound to there, when the excess, essentially glutamate comes along, they can't cause any stimulation and calcium toxicity. So again, that drug effect was predicted by a given theory of Alzheimer's disease. Does it work? Yes, but only to a tiny, tiny little extent. It doesn't cure the disease none of these drugs cure the disease at all. They just cause some small little benefits to accrue. And terminate this discussion of drugs that have been developed to treat Alzheimer's disease, I have a little footnote on the bottom of the slide that's quite sobering. And let's take a look at that footnote. And that note tells us that between the years 2002 and 2012, the FDA, the Federal Food and Drug Administration, approved the clinical trials for 244 separate drugs designed to treat Alzheimer's disease. 244. So imagine the vast resources, money, and research time that went into the development of those 244 drugs. And of those 244 clinical trials, only one of 244 reached the point where it was successful enough to be given FDA approval. And that drug only has very, very small effects. So some of the blockbusters that were planned based on our best understanding of what the physiological basis of Alzheimer's disease is all about have been dismal failures. And like I said, we'll try to talk about that in a bit in the next lecture when we talk about the mechanisms of Alzheimer's disease.